webinar series. I'm very happy to be joined this afternoon with Dr. Irina Prelipcean, who is a neonatal hemodynamics faculty at the University of Rochester, who has a particular interest in particularly diastolic heart function in preterm babies. The topic of focus for today is left ventricular dysfunction. When I started off doing neonatal hemodynamics 20 plus years ago, we talked about biventricular heart dysfunction as if it was the only thing that happened to these babies. And as technology has enhanced, we're now starting to recognize that the right ventricle tends to be the one that bothers us the most commonly in our neonatal population, but when the left ventricle is impacted in isolation, it tends to not be a great thing. And we are very fortunate to have an excellent speaker today that's going to give us some insights into LV function. If people could keep their questions and put them in the Q&A answer box you will see below, and we will hopefully get to them in the Q&A session. And keep your phones off and cameras off. And without further ado, I will hand it over to Irina, who will introduce our speaker and so forth.
Thank you, Patrick. Honored to moderate this important session. And our speaker today is Dr. Gary Beasley. He's the medical director of the Pediatric Transplant and Heart Failure Program and program director of the Pediatric Cardiology Fellowship at the Stead Family Children's Hospital in Iowa City. Dr. Beasley is a recognized leader in the care of children with cardiomyopathy, cardio-oncology complications, mechanical circulatory support needs, and advanced heart failure, including transplantation. Dr. Aisling Smith, is one of the panelists today. All of these panelists have broad and complementary expertise, as you will find out. So Dr. Aisling Smith is a consultant neonatologist at the Rotunda Hospital in Dublin, Ireland. Dr. Smith recently completed a PhD investigating the evolution of the myocardial performance and pulmonary hemodynamics in high-risk neonatal populations, including infants conceived through assisted reproductive technologies, those born on mothers with gestational diabetes, and infants with Down syndrome. Then we have Dr. Neil Patel. He's a consultant neonatologist and clinical innovation director at the Royal Hospital for Children in Glasgow. Dr. Patel serves as the clinical lead for the West of Scotland Innovation Hub and is internationally known for his clinical and research work in neonatal hemodynamics, particularly in conditions like congenital diaphragmatic hernia. And then we have Dr. Jain Kramer. She's a pediatric cardiac intensivist and associate medical director of the CVICU at the Lebanon Children's Hospital in Memphis, Tennessee. Dr. Kramer brings deep expertise in pediatric cardiac intensive care, heart failure management, and ventricular assist device therapy. So we'll begin with Dr. Beasley's presentation shortly, and then transition to a panel discussion. As Dr. McNamara said, please feel free to submit your own questions throughout the session. With that, I'll let Dr. Gary Beasley start.
All right. Can you all see the presentation okay?
Yeah.
Yes, Gary.
Yeah.
Perfect. Yeah. So, good afternoon. I'm Gary Beasley. I'm one of the transplant cardiologists here at the University of Iowa, and I wanted to thank Dr. McNamara and the rest of the organizing committee for allowing me to speak with you all this afternoon about left ventricular dysfunction in neonates. I have no financial disclosures. I will say that I am a site PI for CEDAR HCM trial through Cytokinetics. What I really hope over the next 30 minutes or so to kind of convey to you all is the unique neonatal physiology that contributes to heart failure in this population, causes of neonatal heart failure, and then we'll talk about the treatment of neonates with heart failure as well, talking predominantly about the medical therapies, but we will also discuss a little bit of the surgical or VAD therapies as well as heart transplant. To start off, I'll actually say the things that I won't be talking about. So since this is a talk really focused on the left ventricular dysfunction, I won't be talking about pulmonary hypertension. That's more of an RV issue. I'm not going to talk about PDA management. The neonatologists in the group here are probably far more eloquently equipped to discuss this topic than I am. But the reason I'm not going to talk about it is that it usually causes a transient heart failure related to volume overload or increased preload. I'm not going to talk about high output heart failure or heart failure associated with congenital heart disease, because all of these topics could be their own lecture. So what are some of the things about fetal circulation and the transition to extrauterine life that actually predisposes these infants to having myocardial alterations in their contractility? And one of the things is that as a fetus, the aorta actually sees very low resistance, unlike in adults where we have a much higher systemic vascular resistance. So in fetal life, the placenta is actually the lowest resistance within the circuit, and 40% of the cardiac output from both ventricles goes to the placenta. Also, in fetal life, the RV is the dominant ventricle. So about 2/3 of all cardiac output goes through the right ventricle. So the left really is a more, for lack of a better description, a lazy ventricle in fetal life. And then immediately upon delivery and clamping of the umbilical cord, we have a rapid increase in systemic vascular resistance. If you are an otherwise healthy neonate, term neonate, I should say, we anticipate that you're also going to have a drop in PVR. So we get more towards the quote unquote adult hemodynamics that we typically think of, though it does take a little while for the PVR to fully drop. And then now we have circulation that is in series. And so an entire blood volume of cardiac output is going through both the right ventricle and the left ventricle. And we've also subsequently had an increase in total cardiac output. So what does that look like in a simulated model? So the main portion of this graph that I want you to look at is actually panel C in the bottom left corner. And what you can see is that the solid black line is the pressure volume loop, so volume being the x-axis, pressure being the y-axis of the fetus. And you can see that for the left ventricle, it's actually a fairly small volume and a reasonably low pressure. And then immediately after birth, there's some transient changes that actually decrease it. But by the time you reach an hour to 24 hours after birth, you see a dramatic increase in the volume of the left ventricle as well as the pressure. And interestingly, what you see in panel D is that you see the reverse for the right ventricle. So the right ventricle has much higher volume, higher pressure as a fetus, and by 24 hours of age, you actually have a much lower volume and a much lower pressure. Again, hopefully reflective of the lower PVR, and also reflective of the fact that now it's a 1-to-1 cardiac output, not 2/3 of the cardiac output actually going all through the right ventricle. Interestingly, the right atrium experiences less alterations in its volume and pressures than the left atrium. And the left atrium really, it's not as much of a pressure load as it is a volume load with everything coming through the left side now. So I'll take a second just to remind everyone about cardiac output. So cardiac output is stroke volume times heart rate. And the components of stroke volume that we typically think of are preload. So if we're talking about left ventricular preload, we're talking about the right ventricular cardiac output. So it's what volume is going to come to the left side of the heart. And this really is the stretch or distensibility of the left ventricle. And so things that affect preload are volume status, any obstruction. So if you've got pulmonary issues, congenital heart disease, venodilation or venocontraction can change your preload, either increasing it or decreasing it. So venodilation, if you have a large capacitance reservoir on the venous side, you're not going to have a lot of RV preload, therefore you're not going to have a lot of LV preload. Afterload greatly affects stroke volume. So this is, again, for the LV, this is going to be systemic vascular resistance. Obstruction is also a big thing. So if you have severe coarctation of the aorta or severe aortic stenosis, you're going to have a much higher afterload on that left ventricle. And then we have inotropy or intrinsic contractility, which is mostly controlled by the autonomic nervous system in your catecholaminergic state. So why is all this important? So if we think back to basic anatomy physiology and think about the sarcomeric apparatus, one of the things that we have to think about is the thick and thin filaments and their overlap. And so if we think about the Frank-Starling curve, if we are all the way on the left side of this curve, our thick and thin filaments are overlapping so much that despite being able to try and make that actin-myosin cross bridge, there's just not the potential there to actually generate a contractile force because there's too much overlap. Conversely, if we're on the far right side of this graph and we are too distended, well, now we have our thick and thin filaments so spaced out from each other that they cannot have enough actin myosin cross bridges and actually generate a contractile force. So really where we want to be is somewhere in this middle 2/3 section of the Frank-Starling curve. As a fetus, we're really sitting on the lower left side of the curve. And then again, with cord clamping and the hemodynamic shifts that occur at transition, we start to really progress towards that optimal sarcomeric length and to be able to generate the highest contractile force. So what are some factors that affect the left ventricle at birth and are related to transitional physiology? So I mentioned we have that increased systemic vascular resistance that requires an increased myocardial contractility to now overcome an afterload that it was not seeing as a fetus. We also have a pretty dramatic increase in left ventricular preload and overall stroke volume. And we have increased left ventricular cardiac output with a newly established LV dominant circulation. The other thing of interest and of note is that the environment, the myocardial environment by which cardiac myocytes are thriving in the fetus is that of a fetal hyperplasia or hyperplastic cell proliferation time. And that transitions to a hypertrophic state or an increase in cell size after delivery. And so you'll actually see that within the first few months of life, the myocardial cells will actually grow about 30-fold to get to what we would anticipate to be normal pediatric and or adolescent adult myocardial cells. And why is this important? So neonates have little ability to augment cardiac output through contractility. So they really have to augment their cardiac output through heart rate. So looking at this diagram, again, it's the Frank-Starling curve, and that purple line in the middle is the normal resting Frank-Starling curve. For children, adolescents, adults, we have the ability to intrinsically increase our stroke volume by increasing our inotropic effect. Again, mostly through the sympathetic nervous system. So we can transition from this purple line up to this green line. Unfortunately, in neonates, they don't have that ability yet. They've just gone from being a myocardial complex that's trying to put down more and more myocardial cells to now in an environment where they're trying to actually hypertrophy. And it's that hypertrophy that causes them to have that intrinsic ability to have more inotropic effect. Now, we can certainly use medications and help children and neonates transition into that higher inotropic effect. But the ability for them to do it intrinsically is limited. As they're transitioning into that hypertrophic state of trying to increase cellular volume, they can actually overcompensate. And that's when LV hypertrophy and remodeling happens. It's usually a later adaptation, and it's often maladaptive. Now, one comment I will make about preterm infants. So they are going to have a lot of the same issues that our term neonates would have. But in addition, we know that cardiac motion and cardiac development changes throughout the 40 weeks of gestation. And that preterm and extremely preterm infants have a structurally different myocardium than term infants and even toddlers do. And if you look at the graph there on the right, what you see is that as we progress from 10 weeks all the way up to 19 weeks, not only are you getting increased myocardial fibrils, but you're also getting a change in the array of them. And so we typically think of the myocardium as having 3 different ways with which it contracts. It has circumferential, it has longitudinal, and then it actually has radial or torsional contraction. And it's really that torsional, like a wringing of a dish towel, that doesn't really develop until closer to 20 plus weeks of gestation. And so certainly if you're being born 2 weeks after that, you haven't had much time for your myocardial fibers to actually be in the proper orientation. And so it sets this population up for even more propensity towards heart failure. So what are some of the causes of LV dysfunction in newborns? So on this slide, I call them transient. And I say that because while we generally think of most of these causes as being transient, there can actually be persistence of them as well, depending on the severity. 3 of the most common ones really are going to be neonatal asphyxia and infection. Those 2 predominantly are have a similar pathophysiologic mechanism in that it is acidosis that really drives the cardiac dysfunction. Cardiac myocytes strongly dislike being in an acidotic environment and can begin to develop reduced myocardial contractility in an acidotic environment. Neonatal asphyxia has an increased complexity in that the hypoxia, along with the acidosis, can actually cause pulmonary arterial vasoconstriction, pulmonary hypertension, and reduced pulmonary blood flow, which then causes you to have reduced preload and therefore reduced cardiac output of the left ventricle. And then obviously some of the things that we just talked about on previous slides, if they were to go awry and we have poor transition, then obviously we're going to have some element of ventricular dysfunction, which is hopefully going to be transient as the ventricle figures it out. But in those patients that have refractory left ventricular dysfunction, what are the most likely causes? By and large, the most common fetal dilated cardiomyopathy is going to be secondary to viral myocarditis, typically because of agents that cross the placenta. The most common viral agents are going to be things like parvovirus, Coxsackie virus, toxoplasma, HIV, and CMV. We also see patients, though, less commonly with metabolic disorders, so things like storage diseases, selenium deficiency, carnitine disorders, and other mitochondrial disorders. We can also sometimes see maternal autoimmune diseases like lupus or Sjogren's that lead to myocardial inflammation. We typically think of these types of disorders as causing arrhythmias within or heart block within the children, but it can actually also cause a myocarditis-like picture because of inflammation. A quick aside about the metabolic cardiomyopathy workup. So if we have a patient that we are concerned could have a metabolic component to their heart failure, we do usually recommend a genetics or metabolic team consult. We're going to talk about running things like plasma amino acids in urine, organic acids. We're going to look at their pyruvate levels, their acylcarnitine profile, their carnitine level, and their selenium to try and see whether or not this is a true metabolic disorder. And then the other big bucket of causes of refractory LV dysfunction is going to be genetic, particularly the sarcomeric mutations, so things like myosin binding protein C, things like MYH7, Titin. You're going to have left ventricular non-compaction, whether that is in isolation or a sarcomeric mutation, but it is also frequently seen in TAS gene mutations such as Barth syndrome. And you can see that on the picture here, this is an apical 4-chamber view where you've got just this incredibly thick posterior lateral wall of the left ventricle, but you can see the deep recesses here with the trabeculations. And so this is a picture of non-compaction, again, which may very well be associated with Barth syndrome or maybe in isolation. And then I'd be remiss if I didn't mention fetal arrhythmias. I say it's a refractory-ish cause of LV dysfunction. We typically think that once you control the arrhythmias, the ventricular function should hopefully return to normal or near normal, but certainly depending on the time course with which the patient was in the arrhythmia, how severe the arrhythmias were, you may actually have persistence of the LV dysfunction. But it's going to be arrhythmias like tachyarrhythmias, like SVT, atrial flutter, bradycardias, long QT, or heart block, again, mentioned as the anti-SSA, anti-SSB antibodies. How do we evaluate left ventricular function? So as a heart failure cardiologist, the main thing that I'm going to look at is the ejection fraction. We certainly have other things that we look at, and I'll mention a few of them in a little bit. Shortening fraction was the original way that we measured LV dysfunction or LV strength and quality, but really nowadays it's going to be the ejection fraction, which, just to remind everyone, that's the percentage of ejection from end diastole to end systole. There's a couple of different ways we can do it. We can do it in the apical 4-chamber view or apical 2 chambers. Nowadays, most people are going to be doing the modified Simpson's biplane method to get a more comprehensive view of the left ventricle, but the most comprehensive and best form of ejection fraction is actually 3D echocardiography. I have listed here some of the typical ranges, and this is what is most often seen in the literature, although I will say that there is no necessarily agreed upon range, and most of us actually think that infants and neonates should actually have a much higher ejection fraction than this, but about anything 55 and upward would be considered normal. this is an example of how we would calculate the Simpson's biplane ejection fraction. So we would do in multiple different views, we would trace out the endocardium, both in systole and diastole, and then look at the percentage of that it was ejected. This is what a 3D ejection fraction would look like. So we grab full 3D volumes of the left-sided cardiac chamber, so the left atrium and the left ventricle. And again, looking at in diastole and in systole, the computer then can track along and give us different percentages. So here you see that the ejection fraction was 55%. It's also nice because we can get much more precise volumetric measurements. So we can get an estimate of what is the end diastolic volume, end systolic volume, those types of things, which is really nice. And then there are certainly newer evaluations that we are using as well. So there's speckle tracking and strain measurement, or global longitudinal strain, which is deformation tracking, which I'll show a picture of in just a minute. And that's actually come a long way. And we're using that for a variety of different conditions, both in neonates, children, and in adults. We have tissue Doppler at the mitral valve, which gives us more of an idea of diastology, but can give us a little bit of an idea of systology as well. We have the myocardial performance index, or the TE index, and then we also can look at myocardial regurgitation, DPDT max, which is a marker of sort of how fast is blood moving backwards across the mitral valve, and whether or not it is fast or slow. And if it's slow, we think that there's less contractility. One caveat about a lot of the things that we mentioned on this slide is that they have been investigated in well children. The reliability in neonates is still being studied. In all honesty, for some of these, we're still actually trying to understand what are true normative values for pediatrics in general. So this is what speckle tracking or strain could look like. So again, this is a computer software where it's measuring, depending on the software package you have, either the endocardium or the myocardium, and it's really looking at the grayscale pixels as to how well they are moving. But what it shows us is this left corner is this parabolometric map, where we're actually get a little bit of regionality. So do we think that the septum is mostly affected compared to the lateral wall, or vice versa? Is it the apex? Is it the base? So we get a little bit of that regional wall motion appreciation, but we also just get an overall global sense of what does the heart look like. And what we want to see are numbers somewhere between -18 and -30. Again, systole is obviously contraction, so we want to see a nice negative number. So in this case, all those deep dark red hues that we see on that map there are correlating to an average global longitudinal strain of -21, which would be perfectly normal. These are some of the pulse wave tissue Dopplers that we were talking about, so we can kind of get a sense again. For the myocardial performance index, it's a ratio of your different ratios within the contraction by the Doppler indices that we're getting here. And you can also look at systolic wave tissue Dopplers to get, again, a sense of what is systolic function, but also a little bit of a sense of what is diastolic function. So transitioning to treatment, in the acute phase, we're going to use inotropic medications. Some patients, obviously, depending on how severe or persistent their dysfunction is, this may also become their chronic medications. I jokingly call milrinone vitamin M. It's my favorite medication to treat heart failure. So it is a phosphodiesterase E3 inhibitor. It increases cyclic AMP, causes positive inotropic effect. It increases myocardial contractility and improves stroke volume. It also has some positive lusitropy effects, and so it actually causes myocardial relaxation, therefore improving preload. And it does have some vascular smooth muscle effects as well, increasing cyclic AMP, causing relaxation, and therefore it's we'll often call it an inodilator. So it actually causes some dilation of the systemic vasculature, causing decrease in the SVR. It also does have some effects in the pulmonary vascular bed as well, so it kind of hits both SVR and PVR. Most commonly, you're going to see us use a dose of about 0.5 mics per kilo per minute, but you can go anywhere from 0.25 upwards of 1. The second agent that I personally like to use would be calcium chloride. Particularly in infants and neonates, I think this is a very useful medication for heart failure because we know that the sarcoplasmic reticulum of neonates is immature. And in order to have good, strong contractile elements within the myocardium, we need to have calcium-induced calcium release. So if you look at the diagram there on the right, what we have is the calcium coming in through the L-type voltage gated channels. Then the calcium goes into the cell, attaches to the ryanodine receptor, and releases the calcium stores from the sarcoplasmic reticulum. And all of that calcium together then goes on to the sarcomere that we talked about earlier to really drive that actin-myosin cross-linkage and give us that contractile force. And so cardiac concentrations in neonates is more dependent on that transsarcomeral calcium influx. So this L-type voltage channel, because they have a lower store in the sarcoplasmic reticulum. And so increased serum calcium leads to increased myocardial contraction and therefore improved stroke volume. It does also have some effect in the smooth muscle and will increase your SVR. And dosage forms are anywhere usually from 5 to 15 milligrams per kilogram per hour. And then obviously another favorite medication that we use in heart failure is epinephrine. So it is a beta-1, typically a beta-1 cardiac selective, and then an alpha-1, which is more in the vasculature. It has positive inotropic effects, so it's going to increase myocardial contractility. It's going to improve your stroke volume. It does have positive chronotropic effects, so it's going to increase your heart rate. By increasing your heart rate, it is going to improve your cardiac output. Again, stroke volume times heart rate is cardiac output. But in this case, it's also going to increase your myocardial oxygen demand and your myocardial workload. And so we can sometimes see that they actually, by using epi, we actually put more of a work on the heart. And so a lot of times I'll try to use milrinone and calcium first, and I'll reserve epi for later if need be. Typical doses for the inotropic effects are going to be somewhere between 0.02 and 0.5 mics per kilo per minute. You can probably get away as high as 0.8 or even 0.1 mics per kilo per minute. But beyond that, you're really going to tip more into the alpha-1 properties and have more of the vascular effects without any increased improvement in inotropy. A quick mention about some of the potentially harmful vasoactives. So medications that strictly just increase afterload, so things like norepinephrine, vasopressin, can actually decrease stroke volume and increase LV pressures. And so if you already have a ventricle that is stressed and near falling apart, by adding an increased afterload to that ventricle, you may actually cause it to lose all ability to have a true powerful contraction. So we try to use these with caution and using the minimal dose as possible. So if we're able to stabilize patients on our IV inotropic medications, it's certainly a reasonable thing to try and transition them to chronic therapy if they need it and haven't recovered function. Typically, chronic therapy is going to look like a multi-drug approach, and it's going to be things to reduce afterload reduction. So it's going to be things like your ACE inhibitors, enalapril, or your angiotensin receptor blockers, so losartan, valsartan, things of that nature. We're also going to want to try and reduce the heart rate and also modulate the sympathetic nervous system. And so we're going to use things like beta blockers. My preference for heart failure is actually metoprolol. It is cardiac selective. And so if you've got a kid who has BPD or asthma, you're less likely to cause them to have pulmonary issues by using metoprolol versus something like propranolol, which is not cardiac selective. I also typically tend to use metoprolol even over carvedilol because carvedilol also has alpha properties. And I find that I'm not able to really push and optimize my afterload reduction because I hit a floor with which I can push because of the carvedilol. So my preference usually is going to be either an ACE or an ARB and then metoprolol so that I can really modulate afterload reduction and heart rate independently. Obviously, as they become more progressive with their heart failure, we're going to have to deal with their volume status, and that's where diuretics come into play. And then we'll also use things like aldactone to try and modulate the renin-angiotensin-aldosterone system. A quick aside about some of the new horizons that are coming. I still classify Entresto or valsartan sacubitril as a new horizon. However, it's now been out for many years. We do have FDA approval to use this medication all the way down to age 1. And I do know several centers, myself included, that have used it in kids as young as 3 to 6 months of age if they have severe refractory left ventricular dysfunction. And so what this is it is an ARB, it's valsartan, in combination with sacubitril, which is a neprilysin inhibitor. Neprilysin is the protein in our body that degrades natriuretic peptides. And so by blocking neprilysin, you actually artificially augment your natriuretic peptides, or your BNP, therefore having more natriuresis and therefore diuresis. And so you can see more vasodilation, inhibition of fibrosis, and things with the combination of this medication. It's actually been a huge player in the realm of adult and even pediatric heart failure. We also now are more commonly using SGLT2 inhibitors, which I'll mention in a slide in a second, the mechanism of action behind those. And then we also now have myosin activators. So again, used for DCM, something like ovacaptan mecarbil, which is a medication that actually goes and acts at the actin-myosin site to increase the number of cross linkages and therefore have a better contractile apparatus and contractile force. These are not used in infants and neonates. They are approved for adults, and we are now actively doing the pediatric trial of this. So hopefully, if all things go well, we'll see this potentially available for at least term neonates, hopefully within the next few years. So I briefly mentioned the SGLT2 inhibitors. This class of medications was actually designed to be a diabetic drug, and they found in the adult diabetic trials that those patients with diabetes and heart failure did remarkably better. And so then they started investigating these drugs as a heart failure drug. And what we think that it is doing is that it is essentially blocking some of, again, the renin-angiotensin-aldosterone cycle, and it is modulating effects at the kidney that then allow us to have improved diuresis. And we think that is the main driver with which this medication is improving heart failure. I've actually been able to take some of my patients who have chronic volume overload off of their Lasix with the addition of these medications. And I have used it as low as a patient of 9 months of age. I think we are starting to drift more towards using it in younger children. So hopefully this is on the horizon here soon too. And then if medications fail, we can move to mechanical circulatory support. So in infants and neonates, the only FDA-approved device for patients that small would be the X-Core Berlin pump. This was the first VAD that was approved by the FDA for pediatric patients. It is a pneumatically driven pulsatile pump. Typically, we want kids to be larger than 5 kilos. So even in the neonates, we do have some limitations. And we want the BSA to be less than 0.7, which in your population would not be a problem. You can see here that the way this device works is that we would have an inflow and outflow cannula. So inflow would come from the left ventricle into the pump. Outflow would go from the pump to the aorta. There is a membrane inside here that separates the blood chamber from the air chamber. And essentially what you would do is you would inflate that air chamber, and that would push all of the blood out of the device. And then you deflate the air chamber, and that would suck blood into the device and get ready for your next cardiac cycle. So this is what it looks like when it's in use. So again, the bottom side here is your air chamber. The top side would be your blood chamber. And this device comes in multiple different sizes. So all of these it's sized by the number of mLs that the device holds. And so we have things like 10, 15, 25, 30, 50, and 60 mLs. And then if all else fails, we have heart transplant. It is the ultimate treatment for refractory heart failure. Infants actually have they are the lowest risk group for incidence of rejection, probably related to the fact that they have a relatively immature immune system, and so to some extent become tolerant to their organ. And they have a median graft survival of that transplanted heart of about 24 years, which is the longest of any other age bracket. And if we actually compare that to things like adolescents have a 15 to 18 year median survival. So infants do much better with the longevity of their graft. As you can see, data as of 2019, it's a little bit old now, but the data spanned from 2005 to 2018. You can see that across the age group of pediatrics, infants are still, by and large, one of the largest groups of patients that we are transplanting as transplant cardiologists. And when we look at the diagnosis for which they are transplanted, back in the 80s upwards to the early 2000s, the primary reason we would transplant an infant or a neonate was for congenital heart disease. However, in the more contemporary cohort, you can see that it's only about 57% are congenital heart disease, 35% are now dilated cardiomyopathy, and 8% other, which in all honesty, that 8% is probably things like myocarditis or arrhythmias that are so incessant that we have to move towards transplant. So in all honesty, you're looking at almost a 50-50 split between congenital heart disease and persistent left ventricular dysfunction due to other causes. Here are some of my references. And with that, I thank you all for your attention, and I'm happy to answer any questions.
Gary, thank you. I would just invite Irina and the panelists to join us for the session. I'm going to continue on the role as moderator. Amish is en route, and he will be an intermittent panelist for this year. So, Irina, would you like me to start, or do you want to start, or how you want to play it?
I can start with a question if that's okay. We're going to go specifically to some of kind of the imaging and the newer imaging such as stress, strain, and the myocardial or indices. I'm curious to hear from you what role they play currently in your practice when you assess kind of the progression and, is this reversible versus not reversible LV dysfunction. Just curious to hear a little bit more about the clinical practice aspect of it.
Yeah, so certainly, I think we are starting to try and figure out strain's purpose and utility within pediatric heart failure. Strain really started and came out of the adult cardio-oncology literature, and so we have started to push it more and more. Certainly in the adult and even the pediatric cardio-oncology literature, it would suggest that it is a precursor to overt heart failure or overt decline in ejection fraction. And so a lot of times I tend to use strain more for its longitudinal assessment and less for the absolute number. If I'm seeing a strain is starting to really decrease, I'm starting to get really worried that am I about to have an overt EF drop? Certainly if someone has a borderline EF and it's the first time we're echoing them and they've got a really, really poor strain, then I do worry that that is a ventricle that is probably under a lot more stress than by traditional EF measurements we are appreciating.
It's certainly an interesting topic, Gary. Strain seems to be earlier to be seen and later to go away from an abnormality perspective. Can I just ask, I'm trying to think what I was going to ask you there. Actually, I'll come back to you in a moment. I want to ask Jain, kind of from the cardiac ICU perspective, and Gary talked a lot about the very specific cardiovascular drugs, but it might be good to talk a little bit about kind of heart-lung interaction and do we ventilate these kids, the role of PEEP, et cetera, on LV function, et cetera, and from a cardiac ICU perspective, kind of what thoughts and guidance kind of would you have for the group here? Because oftentimes these babies are not always in the cardiac ICU. In some centers, they're in the NICU, and that's another question I have for Gary. What point does persistent become problematic, and what is persistent, et cetera? So.
Yeah, I think it's a fascinating question because obviously there's a lot of non-cardiac drug management that we have in the toolbox for these kids. A lot of it, from my perspective as a cardiac intensivist, is dependent on functionally where the kiddo is. If we're dealing with a child who is maybe tolerating a little bit of enteral nutrition and is able to maybe grow, has one of those more transient causes of LV dysfunction, I think my calculus for positive pressure mechanical ventilation shifts towards maybe not for this child. You have a kid who has a pathology that is going to probably not improve. They're not able to tolerate enteral nutrition. then I really do favor at least a trial of mechanical ventilation to see if you can allow the heart failure medications time to recapture the child. And that comes back to the concept of cardiopulmonary interactions, where by using positive pressure, you decrease the afterload on the LV. Obviously, it's nowhere near as simple as one side of the heart. When I use positive pressure, I have to be very cognizant of the effects that it has on the RV, decreasing preload into the RV, increasing RV afterload, which obviously if I have a slightly struggling RV, which in the setting of LV dysfunction, I may have transient RV dysfunction, and that act of transitioning from negative pressure ventilation to positive pressure ventilation would be very challenging for these children, and making sure that you're actually adequately volume loaded, avoiding diuretics in that transient period may be very helpful so that you maintain that stroke volume, because as we decrease the preload to the LV, obviously, we are also not helping that stroke volume. Additionally, that gets into, I think there was one question in the chat about using Precedex for sedation. The active intubation and mechanical ventilation gets at how do we make a sedative choice to reduce both metabolic demand for the child, because obviously that's optimizing end organ perfusion, but not sacrificing that necessary tachycardia that the patient has. So I use Precedex pretty commonly in these neonates, but I try to keep it at very low doses and just trying to tolerate, kind of just enough sedation. Where I found that Precedex gets you into trouble is if you're at high dose Precedex and you blunt their natural tachycardia, then you don't have as much cardiac output, and you can really get yourself into trouble that's hard to rescue from. Because I find once these infants go bradycardic, it's really hard to get them back.
Yeah, thank you, Jeff. Irina?
We have a few questions regarding, so I wanted to, shifting slightly, I would say, but still in maybe Jen and Gary can answer those, regarding calcium and chloride, and how often are you checking serum calcium levels, and can you comment on total versus ionized values to guide this therapeutic use in heart failure?
Yeah, so I typically am looking at ionized calcium levels. I don't look at total levels nearly as much. We will occasionally check it. Typically, we're looking at ionized calcium levels at least once a day. Depending on your scale and the units with which you're measuring it. Back at Le Bonheur, it was somewhere around 1.4, 1.5 is what we were typically targeting. Here, it's typically 6. And again, it just all depends on the units with which you're doing it. But I have found that neonates tend to be very lenient when it comes to quote unquote calcium overload. I have actually not had, that I can think of off the top of my head, any serious adverse events from using calcium as an inotropic agent.
Yeah, I'd agree. I don't typically worry about overshooting on a level. I will check a total calcium at least once a day when I have a kid on a calcium infusion, and it's predominantly making sure that as we're doing nutrition, whether it's enteral or parenteral nutrition, that I'm not running the risk of calcium precipitates if their FOS is also rising. And typically that becomes an area of concern if we're having renal dysfunction secondary to their heart failure. But otherwise, I just kind of a once a day ionized calcium level. And I agree, I've not yet seen toxicity, and I've certainly seen some high ionized calcium levels.
I think Amish has his hand up. I don't know if you want to make a comment on that, Amish.
Yeah, I'm just trying to, be alive here. That's all. I'm driving. I'm so sorry, guys. I just not going to be able to communicate all the time. One of the question about calcium is, and I personally struggle, and I'm sort of the question for everyone. How well does serum calcium level, even ionized, reflect myocardial calcium availability? Is it a direct relationship, or is it just a surrogate? Point being, if you have severe myocardial dysfunction, and even if the serum ionized calcium is low normal, would you still give it because it's just not completely reflective, or would you be reassured that's enough calcium available?
So I will say in my experience, even patients who have a normal or even high normal serum or ionized calcium level, I've started on a calcium infusion as an inotropic agent and have seen a positive response. So I don't know of any literature that sort of describes the linearity of it. But from at least a clinical practice, I have found that, I'm following the serum calciums, I think, more to make myself feel better, that I'm not super therapeutic, more so than I am for guiding my therapies.
Okay. I would just go ahead.
One more, and would you give calcium as an ionotrope in hypotensive babies even without LV or heart failure in general?
Yes, I have found that if you're trying to improve blood pressures and improve just overall cardiac output, calcium has been a great choice in this population. Toddlers, older children may not respond as well to calcium, but infants in particular respond very well to calcium.
Okay. I want to pivot. I will talk to my good friend, Neil Patel. Neil, I'd love to just talk about maybe some of the lessons we've learned about the LV and CDH, because I think obviously that's your expertise, and I think we're still at the discovery phase and are learning that not every baby who has a kind of LV dysfunction, it doesn't always go away very quickly and can be refractory in some patients and so forth. But you have a lot of experience in managing these kids. What thoughts and perspectives do you have for the group here? Because it's a difficult population.
Yeah. Thanks very much, Patrick. And thanks, Gary. Really great talk. Really enjoyed it. Learned a lot. With regard to congenital diaphragmatic hernia, in particular, as Patrick says, we've spent a lot of time, first of all, recognizing that it wasn't just about the right heart, and that the left heart might be unhappy in that situation, especially in the acute neonatal transitional period. And then trying to understand the timing of that, the propensity for it, its association with other markers of disease severity, and then the natural history of it. And still continuing to try and understand that a lot. It's in relation to the parameters used to assess left ventricular function. It's interesting because I certainly started out using things like myocardial performance index and then tissue Doppler. And it was interesting because we didn't detect as much dysfunction in the left ventricle using tissue Doppler to look at basal longitudinal velocities as we did in the right ventricle. And that was, for me, certainly early on, that was part of a reason why I wasn't quite as impressed with left ventricular dysfunction as with right ventricular dysfunction in that population. And it was only once we started perhaps to use more global measures of function, including strain analysis, that we got a much stronger signal of what we were seeing subjectively, which was dysfunction in that group. And also, I think that came with us looking very early in the transitional period and realizing that these patients appeared to have left ventricular dysfunction right from the get-go. And I think, again, we're still trying to understand, is that something that happens at the point of birth, of separation from the placenta, or is it happening even before that to some degree in CDH? And then I think I was also really interested in your approach to therapy. And certainly a lot of the medications that you mentioned are ones that are well established in the toolbox for CDH. Milrinone has been there for a long time. We're looking forward to the results of the Milrinone trial in CDH, led by Sachin, and what that's going to show. I was really interested in this conversation around calcium and calcium levels, also because there are reports, including from the group of Florian Kipfmüller in Germany, of using levosimendan, calcium sensitizing agent, in the CDH population. And I'm really interested in your thoughts about that drug in general, since we're talking about calcium. And then the other wider thought that I was having as I was listening to you speak was how, certainly in the acute phase, perhaps our focus is more on inotropic support. We want to make that LV work better. But then as we shift more into chronic management, we as you nicely described, Gary, the armory there is more about afterload reduction. And it sowed a seed for me, which is, when is the right time to think about pushing that left ventricle, even though it looks like it's failing? And when is the right time to think about reducing what the resistance that it has to work against? And what measures in the future might help us to find that balance, that fine balance, better? Really interested in yours and the panelists' thoughts on that.
Yeah, I mean, my clinical approach has always been, if we are having such severe ventricular dysfunction that we are on IV inotropic support, I typically will leave patients on that for a minimum of a week, mostly just for myocardial rest. And then at that point, if we have seen hopefully some improvement, although maybe it's not back to quote unquote normal, is when I would feel a little more comfortable of trying to push that ventricle a little bit and see, can we make a transition to an oral therapy? And typically the way I do that is I will, if I'm on higher dose milrinone, let's say, 0.75, I'll first try to wean that down to 0.5. If I can tolerate 0.5 without any hemodynamic changes, then at that point, I will slowly start to institute either my ACE or my ARB, and I will slowly ramp that up over the course of, 5 to 7 days while I'm on both dual therapy. And then once I get to a reasonable dose of ACE inhibitor, if we haven't had any hypotension, I'll start to turn down the milrinone and I'll do it gradually. I'll go a little bit at a time, make sure that the ventricle is handling the decrease, and really just kind of do a drawn out transition. And if I see at any point, either by hemodynamic parameters or by echocardiography, that the LV is starting to slide backwards, I haven't lost ground. I'll turn the milrinone back up and usually then hold for at least another 2 weeks or so before saying, all right, I'll try one more time. Usually in that interim, I might start adding additional things on board too. So I didn't talk much about beta blockers in this because, again, in the acute phase, we don't really want to be using beta blockers, especially if we're on epi and those types of things. But, if we've now entered into that chronic phase and I'm trying to see if I can get them onto oral therapies, that's when I'll try to optimize my beta blocker. I don't use a lot of digoxin anymore, but certainly if it is a kid that, I'm trying to avoid VAD or transplant, I will use it as a sort of last ditch effort just to see. And if I'm not able to separate from milrinone at that point, that's when, a lot of times when I'm saying, okay, we've tried, we've pushed, we got to go to advanced therapies like a VAD. Your comment about the levosimendan, I'll be honest, I don't have a lot of experience with that. From talking with colleagues around the US, I think we kind of have abandoned that as a therapy. So I'll be curious to see if the trial out of Germany actually does have any positive results and then sort of re-sparks the interest in it.
Yeah, I think my understanding is we can't get it. It may not even be available now unless someone is telling me. Have you heard that people have been able to get it?
I've heard of one person getting it for compassionate use, and that was it.
Okay.
Ashley, you have your hand up.
Yeah, thank you, Gary. That was such an excellent talk, and I definitely learned a lot from you. As a neonatologist, and obviously you made reference to it in part of your talk when you showed those beautiful pictures of the orientation of the myocardial fibers. So I suppose my question leads on from Neil and your discussion about the medical therapies that are available. And I suppose, do you think that there's, that premature babies who are in LV failure and who have different myocardial fiber orientations and stiffer hearts, do you tailor your medical therapy different to preterm babies in LV failure when they're entering their chronic phase, different to term infants who perhaps have viral myocarditis? Or, do you think the nuance exists yet, or the literature exists yet for us to be able to make those more like nuanced medical therapy decisions? That's kind of my first question. My second question, if I may, and forgive me, I'm a neonatologist, so I'm not that familiar with using VADs or taking care of infants who have VADs. But just from PDA device closure, we're able to put devices into smaller and smaller and smaller babies. So you said 5 kilos was kind of your cutoff, but do you see a potential that the VAD devices, is there anything in development for even smaller babies at 2 kilos or 1.5 kilos? So they'd be my 2 questions.
Yeah, so I'll answer your second one first. So there was the Pumpkin trial that came out, which was basically a call for people to have innovative ventricular assist device approaches to be able to address the neonates and the smaller children. And about 10 different devices were initially put forward in that, and only one really came out of it, which is the Jarvik. And last I had checked, which was several months ago, I think we were up to about 12 infants across the U.S. who have been implanted with the Jarvik. It is a much more afterload sensitive device, so it's yet to be seen how well it's going to work. But it's roughly the size of a paperclip or a AA battery. So it is much smaller, can be used down to about 2 kilos. And so I think, you know, if we can get the mechanics of it right, would be a huge game changer for us. You know, I think your first question about sort of that precision medicine of the neonate and the preterm infant, I think is a great question. I think right now, I think the literature probably is, we're moving in that direction to understand that precision. I don't know that we're fully there yet. And the bigger issue that I have is I don't have a great armamentarium of things to use. And so unfortunately, you know, in pediatric heart failure, I'm using stuff that were designed and used for adults. And so trying to make that jump from adults all the way down to preterm infants is really hard. And so I have to some extent use what I have, knowing that, and my current thought process is knowing that if it's a preterm infant with, you know, potential myocardial fiber disarray and other things, that I'm going to hit them with my current therapies as best I can. And they just may not work because it's probably not what that infant needs. But we don't have a ton of stuff right now necessarily to alter the course.
I'm curious, also a follow-up question to that. I'm a neonatologist as well, and don't deal a lot with it. But how early do you consider this mechanical circulatory support? I mean, what are the thresholds when you move from, you know, towards that or listing or?
Yeah, so certainly if I'm moving towards mechanical circulatory support, I'm listing for transplant pretty much concomitantly. It's rare that I will do VAD without transplant unless I think that this is a fulminant myocarditis and I just need some transient support. But you know, certainly if I'm thinking this is a dilated cardiomyopathy or a metabolic disorder or something of that nature, I'm probably going to do both at the same time. We certainly have a classification of, you know, how sick are you? Are you stable on inotropes? Are you getting worse on inotropes? And that kind of helps us to decide when do we need to move forward with mechanical circulatory support. In all honesty, a lot of times my rule of thumb is if I have pretty much maxed out IV support and I have 2 systems involved, so heart and if I start to have feeding intolerance or I've got renal dysfunction or my liver enzymes are now becoming abnormal, I usually will say that that's time to move forward. I think as a field, we have become much more inclined to place a device early because we know that overall the outcomes are better, both from a pre-transplant survivability, but also a post-transplant survivability. The highest risk for mortality after transplant are patients who had to have ECMO. So if we can avoid ECMO, even if that's putting a ventricular assist device in, we have a much higher chance of success after transplant. And so I think most of us in the field would say if you're maxed out on inotropic support and you've got 2 systems involved, we're just going to go forward with mechanical support.
Let me, I don't know if Amish is able to join, but I've got a, just to be a bit more provocative question for you. So kind of Gary put up on one of his slides, vaso as a no-no, so to speak, in terms of the LV. And obviously, you know, I think everybody's clear, if you've got isolated LV dysfunction, you know, that makes a lot of sense. But things are not so simple and straightforward in the NICU. We have babies that have sepsis with heart dysfunction, which may be biventricular, oftentimes, in which the LV may be affected, and or babies with pulmonary hypertension that have some LV dysfunction. And kind of what are your thoughts on vaso? I know you've published a lot on vaso as a classic therapy for hypotension and pulmonary hypertension babies.
Were you speaking to me or to Amish more?
No, Amish. No, I'm sparing you from that question, Gary.
So you and I have debated this already.
Yes, I know. I just brought it on here. Amish, go ahead.
Yeah, sure, Patrick. I'm going to put it out there, and then maybe Gary, you and I can debate separately some other time. So, yeah, I mean, it's an interesting question, right? I mean, for some reason, the very simplistic idea is that vasopressin will increase afterload, and that is going to cause LV dysfunction or make LV worse. but that simplistic explanation doesn't take into account the cause. So for sure, if you have normal blood pressures or you have slightly low borderline blood pressure and isolated LV dysfunction, you don't want to increase blood pressure that much, the LV faces high afterload. But my understanding of physiology of a drug causing LV afterload increase is through the mechanism of increasing the blood pressure. So if you give a pressor of any type and your blood pressure goes too high, the LV will be basically, that will indicate a high SVR state induced by the drug and hence can increase the afterload. But a kid whose mean blood pressure is 22 doesn't have a high LV afterload from an SVR point of view. And so when we are using vasopressin in a pulmonary hypertension or even septic shock to normalize a hypertensive state, I don't see, either clinically or not physiologically, why that should cause a LV afterload a problem unless somebody can tell me that there's a direct effect of vasopressin on the LV myocardium independent of the systemic blood pressure. I'm open to learning from that, but for me, it's not a contraindication at all. It is about managing the cause, and we've done it many, many times.
And I would agree with that. I think I caution more of just having a rapid increase in SVR and causing that LV to fall apart.
Yeah, I think the other piece as well, I think everybody would agree here, having low diastolic pressure and someone with LV dysfunction is not a good thing for the coronary arteries, and normalizing that is potentially good. And obviously the vaso has got a lot of attention in neonatology because of its more favorable effects on the pulmonary vascular bed as opposed to using dopamine, and that's where that kind of has evolved. But again, that's been our experience, you know. Now in saying that, Amish, we had one baby recently, which surprised me that even in the presence of a blood pressure that was just about normal, the LV got worse. So I think your comment I fully agree with, but there may be the occasional baby that if we give vaso, that we probably just need to you know, the kids is not doing well. It's like anything, you just reevaluate and so forth. And that baby, we actually had to tolerate a slightly lower blood pressure for a period of time because most of his pulmonary hypertension was actually more left heart driven. So.
But I'm more concerned with vasopressin causing a chronic vasopressin use, not acute, not short-term acute, causing a fluid retention and that putting a load on the LV. I think that's a fair concern that when you use, and in my experience, it happens when you're more than 36, 48 hours on it, you start seeing fluid retention and a hyponatremia. And I think in a failing LV, you don't want to stretch that LV myocardium preload even more. So I think that's something to worry about for sure. But again, I mean, if we have a slightly lower blood pressure because of low cardiac output, but the SVR is normal, then I think your point is valid that if you're increasing the SVR simply to increase the number, and the actual SVR or the stress felt by the LV myocardium is increased, the output may likely go down even further. But in cases of septic shock, for example, when the SVR is really low, even if there is a concurrent LV dysfunction directly from sepsis or maybe because of low preload, I don't see that as a contraindication for vasopressin per se.
Yeah, I think the comment is here, thoughtful use of, you know, medications. Can I just ask, just one thing didn't appear. I'm going to pose this question to Jen. We haven't heard it for a while. So the word dobutamine didn't appear on Gary's slide, and it's probably the most commonly used medication in NICU for mild heart dysfunction, whether it's a little bit of RB or biventricular dysfunction. Kind of, you know, has that fallen out of favor kind of in the CVICU world completely, or is it ever used?
So I think, at least in my experience in our practice, in most of the centers that I've, you know, surveyed, we prefer epi. I still think there's a role for titrated dobutamine, especially, you know, if you don't have a lot of other options. You know, low dose can potentially provide you a lot of benefit. I know some of my European colleagues have favored dobutamine for some of their heart failure patients. And I know certainly in adults, there's still some, you know, use of it for those patients. But overall, find epinephrine, it provides a better balance between inotropic support for the heart and not generating too much excessive chronotropy. Because one of the things we didn't touch on is maintaining these kids in a normal sinus rhythm is so important because they are dependent on atrial kick for a chunk of their cardiac output. And so agents that potentially precipitate an atrial attack, especially if they've developed any LA distension and have potentially a nidus for that can really get you into trouble. And that's why I like epinephrine, because I just find it a little more controllable in terms of getting what I want and not getting side effects.
I wanted to shift a little bit because, this is kind of the more nebulous area and at least in neonatology that we're starting to learn more about, which is the LV diastolic dysfunction. That's my interest as well. And I had to bring it up. Do you, for either Gary or Jen or whoever wants to kind of take a stab at it, do you, how do you approach defining it in the pediatric population without a validated criteria, and kind of what are the struggles of clinically identifying those that have isolated diastolic dysfunction versus and how do you strategize in regards to therapies when you see it?
I think diastolic dysfunction is an incredibly challenging entity. I think the adult criteria that we have, for one, is poor at best. And so I don't think that we have really been able to identify it in adults, and therefore we can't identify it in children. And so I think even pulling that down into the neonatal population is hard. If you talk to heart failure cardiologists, pediatric heart failure cardiologists across the country who've been doing this for decades, they'll tell you, well, you know it when you see it. You look at the echocardiogram and you can tell that there's diastolic dysfunction. And to some extent, I get that. If you're seeing sort of that double hit on your LV, well, sure, we normally shouldn't be able to see the atrial kick transmitted down into the LV. But things like, your TDIs, your tissue Dopplers, do the adult criteria for that really hold? I don't know. What I have found is that, to me, probably the most sensitive marker is left atrial dilation in the absence of any mitral valve regurgitation. If you're having left atrial dilation, it's probably because you've got an elevated EDP, left ventricular EDP, that's transmitting its pressure across into the more compliant atrium. And so that's when I really start to say, okay, now we need to be doing something to try and modulate that. And unfortunately, treatment of diastolic function is also incredibly challenging. We don't really have anything. There certainly milrinone has this theoretic lusotropic properties that may be able to help. And I think that's one of the reasons why so many of us that do heart failure use milrinone, because we do hopefully get some of that relaxation. But outside of milrinone, there's really not much else that we can offer. Some of us will use, myself included, will use beta blockers, not because it actually causes any sort of relaxation, but if we can at least blunt the heart rate a little bit, allow for a little bit more diastolic filling time, we're overall going to improve cardiac output. But it's really a Band-Aid. We're not actually addressing the underlying pathophysiology. We're just trying to improve cardiac output. And I see this, I deal with diastolic dysfunction in older children with sickle cell or with chemo-induced cardiomyopathy. It is just a very hard, nebulous diagnosis and entity to treat.
Thanks, Gary. We're almost up at time. There's one question that's just appeared on the chat, and I'm going to pose it to you, Ashley, from my good friend Ram in California. Does dopamine have any role in modern times? I kind of thought it was extinct, but maybe it's not.
Dopamine.
Do you want to have what are your thoughts on that? You or Neil, the people I haven't heard as much from.
My thoughts on dopamine, I think we have more selective agents to do a more precise job than dopamine, would be my diplomatic response. So, if I don't have any central access and all I have is one peripheral cannula in a 24-weeker or something, fine, I'll use dopamine just till I can get some central access. But that would be the rare and only circumstance in which me or my colleagues in our institution would use dopamine. I think there's a lot of evidence about the extracardiac effects, and I think we just have cleaner, better, more effective medications to target the physiologies that we see.
Neil, anything from you? And maybe again from the PICU perspective, kind of CVIC, are you guys using dopamine?
Yeah, just to back up everything that Aisling said already, and I think also just what we know from the past is that a lot of these medications were used as drugs of last resort and in high doses, and we saw the side effects having adverse effects rather than lower doses having beneficial effects. But going back to what Gary was saying there about trying to manage potential diastolic dysfunction by heart rate control. I think one of the concerns with dopamine is its chronotropic effects and what effect that might be having on diastolic function, coronary perfusion as well. So yeah, agree with everyone else's sentiments about making it a historical drug in the future.
Well, not yet. I've let my study finish first.
Yeah.
Sorry, once Amish is finished, then we can, yeah.
Yeah, if centers don't use, I'm already struggling to get into dopamine centers. So if anybody is using dopamine for septic shock, reach out to me. I need your data.
That's we got you on camera with the word dopamine.
No, but no, I just fucked. But I think we can't discount the fact that it's a historical drug in our population, right? So the fact is, majority of neonatologists, or the majority of published experience is with dopamine. So yes, the newer drugs from our thought processes seem to be more precise and seems to, like, we know what we are targeting. We can't just rewrite history based on theoretical. We have to generate data and to say, okay, this works better or this doesn't work better. There's also, being a devil's advocate, at least in the premature patient population, the alpha receptors predominate. And which is why dopamine seems to work, at least from an SVR perspective and blood pressure perspective, which is what a neonatologist would want, seem to work quicker and at a lower doses. And I think that's what drove a lot of this early use of dopamine, because patients who are hypertensive responded to it and their blood pressure normalizes quicker compared to, say, Patrick mentioned, dovitamin is another drug which is used a lot, and I completely stopped using it more or less. Because you have better agents who can do more selective work and better work in situations. But the empirical treatment with dopamine does increase blood pressure. So we'll have to demonstrate that increase in blood pressure does not cause the patient outcome improvement before we can actually make it historical.
Yeah, good point, Nash. Jen, any quick comments you want to make from the PICU perspective?
I mean, I think Ethan said it the best. We have much better agents that do our job selectively. So I think outside of septic shock, where you have one peripheral and you need something quick, I mean, the advantage is it is a premixed bag and it's right there on hand. But I'm switching over to something else pretty quickly.
Yeah.
Perfect. Irina, do you want to wrap us up? Because it's 2:15. People have done a fantastic job.
And I think we're at the time. So, we thank you. There are a couple of questions in there in the Q&A, but we'll try to answer those separately after or outside the call. But thank you everyone for this fantastic discussion, for all the viewpoints from kind of across the pediatric population. It's very interesting to see all the similarities. For me, it's very, very interesting talk and great insights into how we can what we need to investigate going further, including dopamine, Amish, and then how we can what we can focus kind of our next academic pursuits in this domain. But thank you everyone again.
Thanks everybody. Thank you, Gary. Thanks everyone.
Thanks, guys.